Pump standby, when and how? So what do we do pump standby for? We do it for OpCab, we do it for TAVR, we do it for pericardial windows, we do it for convergent procedures, we do it for lead extractions, and we do it for Watchman procedures. So we do it pump standby for a whole bunch of different things. The real question is, how do we do pump standby? And I think there's huge variation across the board with how we are all doing this. I want to illustrate some of that with some of these next slides. So, and I need to look at my computer at the same time because the text is rather small. But let's read this. This is very interesting. Development of our TAVR, they call it TAVI. And just so you know, TAVI and TAVR are the exact same thing. The reason that they call it TAVR here in the United States and TAVI in Europe is because here in the United States, you cannot be reimbursed or paid by CMS for an implant, but you can for a replacement. So if for us, it's transaortic, transfemoral or whatever, aortic valve replacement versus aortic valve implant. That's why that is. But all transcatheter aortic valve implantations or replacements cases are done in our hybrid operating room with a multidisciplinary approach and a primed cardiopulmonary bypass circuit on pump standby. Now, one would think that that's always the case. We decided that we would resuscitate all patients undergoing TAVI procedure via a transfemoral, transapical, or transaortic approach, if required. Perfusion plays an essential role in providing rescue CPB for patient salvage when catastrophic complications occur. To coordinate the multidisciplinary effort, we have developed a written safety checklist that assigns a predetermined role for team members for the rapid sequence initiation of CPB. Although many TAVI patients are not candidates for conventional aortic valve replacements, we feel strongly that rescue CPB should be offered to all TAVI patients to allow the correction of potentially reversible complications. Now, they might go into VFib. In fact, that happened to me today. The protocol is included in every surgical timeout involving TAVI and TAVI procedure. The protocol has led to rapid and safe CPB initiation in less than 5 minutes of cardiac arrest. It has also led to coordinated and consistent team with pre-specific roles and improved communication. Now look, that was a whole lot of verbiage, but what they're saying is they have the pump in the room, primed, and a perfusionist on standby actually as part of the actual team that's performing the procedure. And even with that, it takes 5 minutes, and if the patient, of course, is in VFib, then they're being resuscitated for those 5 minutes. Hopefully the resuscitation is good or the CPR is effective, but that still takes 5 minutes. And I think that's probably being pretty generous to themselves, at least that's my thought, because I've been in these circumstances before, as many of you also have. So they go on to discuss these carrots and the merits of the protocol and so forth. But what I found was this survey that was done. And when you look at this survey on perfusion coverage for TAVR procedures, I'm going to go through the entire survey. But if you look at it, number one, centers performing TAVR commonly have case volumes greater than 400 CPBs per year. The average program performs between 20 and 50 TAVRs per year, and some centers doing over 100 TAVRs per year. Most procedures are performed in a hybrid room, and it goes on to explain these various things. But this is a very interesting study that was, or survey that was done by Cardiology Review in 2013. And let's go through each of these slides. See, I'm not switching the thing. And this is the study that I'm talking about here. Okay, so let's go through that first slide. So this is where it was published, and you can see it on there. And now we'll go through the first slide. What is your total cardiac surgery volume? In the choices, greater than 1,000 cases was 34% of the respondents. And if you look down here, you can see that the total respondents was about 100, okay? Or was 100, I should say. Doing between 750 and 1,000 was 11%, between 400 and 750, 35%, and between 200 and 400, 17%. Less than 200 was only 3% of the total respondents of this particular survey. And then going to the next slide here, it asked which best describes the circuit you use for TAVI procedures. What I found interesting was full circuit with suckers, cardioplegia, and heater cooler. In other words, the full cardiopulmonary bypass circuit was 87%. Mini circuit, like having an ECMO, which is what I was using today, is only 3%, and a modified circuit with small heater cooler and modified suction and cardioplegia was 10%. Now, I don't know what, I guess that's just a mini bypass circuit. Maybe they used a smaller machine that only had, 2 roller pumps and a centrifugal, so kind of like a bigger ECMO, but a smaller heart-lung machine. That's what I'm assuming that is there. Do you prime your pump? So of the respondents, there were 99 respondents, so somebody didn't respond to this one. 79, almost 80% responded that they in fact do prime their pump. And in this study, 20% said that they did not. Now, of course, we all are going to ask, as soon as I saw this slide, I said, well, I had a follow-up question to it, but don't worry, they asked too. I thought that was interesting. Do you reuse your primed standby pump? So you didn't use it for the TAVR. Do you use it for the next TAVR? Or do you use it for a heart case or whatever the situation may be? Which begs the question in my mind anyway. In fact, let's bring Nate in. Hopefully we got that technical issue resolved. So let's bring Nate in and adjust the camera. There you go, so I'm not half cut off. Hey, everybody. Hey, Nate, okay, you got the YouTube turned down, bud? Nope, now I can't hear him at all. It's just all going to heck in a handbasket here.
Joe, can you hear me?
Yes, I got you. Yes. Good. Okay. We're good. Okay. So here's a good question that I like. So this is Nate Bedair. He was on the program last week. Nate, it's great to see you. Thank you so much for doing this.
For having me.
So we're talking, I'm assuming you heard my beginning of this thing and my talk, and we're discussing whether you reuse your pump. How long, if the pump is primed, do your hospitals allow you to reuse it if you want to, once it's primed?
3 to 5 days.
3 to 5 days. And what is that based on?
Sorry, go ahead.
What is that based on?
Just what the protocol, what the people who were there before me did. No, nothing other than that. I mean, I know there's some tests that show after a certain amount of time, or some studies that show after a certain amount of time, there's some issues with infection, not an infection, but bacterial colonization. But other than that, and I've seen the studies, but I couldn't tell you what they were. It's been a while. Mm-hmm. Other than that, that's what people did.
Mm-hmm, mm-hmm. Yeah, it's a good question. I don't know the answer. I'm sure that there's probably across the board. I've seen people who have said once it's primed, tear it down. I'm curious what any colleagues of ours may think. I'd love for them to respond either on the YouTube chat or call in. I've seen, you know what, it's one patient and you're done. I've seen 1 day. I've seen if you use it tomorrow morning. I've seen 3 to 5 days. I've seen as long as a week. And I've seen a few times where it's actually been longer than that.
I have heard that as well. I know we have a colleague that we work with at another facility that even a dry setup, when she's done with it, she's done with it. she not destroys, she tears it down and throws it away.
Uh-huh.
She probably or not. And that's, that's just the way she's always done it. Where one of the facilities I used to work at, we set it up and it was good for a month.
Mm-hmm. A month.
A month.
Well, and I've seen that with the old Centromag, what used to be Thoratec. I guess it's Abbott now. And I've seen on the them having that up for 28 days, and then at 28 days they tear it down and put another one up. And those things are, if they didn't use it, those things are $25,000 a pop.
That's probably why. To be honest with you.
Say that again.
That's probably why.
That they don't tear it down for 28 days.
Because of cost.
Yeah, I agree. But, is there a way? I mean, I don't know. It's interesting. It's an interesting problem. But anyway, let me go on to the next slide if I can. We're going to cut you out for a minute, Nate. I'm going to go on to the next slide.
Yeah.
So on this slide, can you, that's good. Where do you perform TAVR and TAVI procedures? And this is another good one here. Cardiac cath lab was 21%. The hybrid room was 66%. So most people are clearly using hybrid rooms. The cardiac operating room was only 1%. And then in multiple sites was 12%. So I would assume that would be the cath lab and the hybrid room. So I thought that was fairly interesting. And then coming over here to this slide, it's asking, how often do you go on bypass for TAVR or TAVI? Now, that's another really good question. How often are you using it? Well, almost never, which was 0 to 2% of the time, interestingly, was 64% of the responses. Rarely, 2 to 4% was 27% of the time. Sometimes 5 to 10% was 6%, and more often than 10% was 3% of the time. So rarely and almost never really dominated this. So let's go back and bring Nate back in, because these are some really good points. So Nate, based on that information, when you look at the preliminary comments that I made that were written, where they said that they put every patient who has a problem on some type of support to see if they can correct the problem. And this was something I feel was an issue some years ago when we discussed this. We would say, well, if the patient isn't a surgical candidate, now in their case, they said that they had some patients that were not surgical candidates, but they still put them on TAVR. They still put them on bypass of whatever form, ECMO or whatever it was, to support them to see if they could correct the problem. But if they're not surgical candidates, other than that, wasn't that the argument? What are we doing this? What are we even here for? Why are we even here? Have you not heard that before? Why is the perfusionist even involved if we're not going to take this patient to the operating room to correct the problem?
Yes. But at the same time, it is a hybrid unit. That's the whole point of it, right? It's a hybrid room.
Mm-hmm.
That's the whole point of having a hybrid room, so you could have the perfusionist in there while they're using the other equipment at the same time, or the whole surgical staff in there, whether also it's half cath lab too.
Right, but how do you address the issue of we're doing TAVRs on people as essentially palliative care, and then the patient has a problem, and now you put the patient on ECMO, and you can't correct the problem, but the patient's not a surgical candidate, and now you have a patient on ECMO. When do you turn that off? Who turns that off? What's the ethical considerations that go along with that as a problem? I mean, how are you going to address that with the family? We put them on mechanical support.
And you and I both know, and everybody out there listening knows, that comes down to what the surgeon wants. We, many times, unfortunately, we run ECMOs on patients that we are pretty sure have no chance to survive any longer. Mm-hmm. But what do? We keep working as long as the surgeon says you have to keep working. Ethically, at some point, I'd like to think we have a say as perfusionists, but beyond just telling the surgeon, hey, I don't really think there's a good outcome in this situation, I don't think we have much say in the final scheme of things. And some surgeons take that into account more than others. Some surgeons just, and in my experience, just say, "Oh, okay," and they ignore it. And other surgeons will take that into consideration, and and as they move forward.
That's good. Okay, that's a really good point. Okay, so let's go back to my slides again, please. So this next slide asks, how many TAVRs procedure does your center do? 0 to 20 per year was 20%. 21 to 50 was 37%. 51 to 100 was 24.5% or 24.7%, and greater than 100 was 18.56%. Again, only 97 people responded, so 3 centers didn't respond, or 3 people didn't respond to this particular survey. Look, I can tell you right now, where I was at today, they did 4 TAVRs today. They do in the neighborhood of 360 TAVRs a year. So there are some places who are doing a lot. They clearly didn't respond to this particular survey, but there are some very high volume TAVR programs, which surprises me because, I never saw that many AVRs in my entire career. So I'm kind of surprised by that number, to be frank with you. But this is another good one. Which statement best describes your outlook of TAVR? So let's just go to the dominant one. 42%, that's down at the bottom. It is too early to tell how these procedures will make a difference. The next highest is these procedures will have greater application in the future and reduce pump surgery volume. And then at 17%, that was the second one, that these procedures will add more opportunities for perfusionists. 17% felt that these procedures will add more opportunities for perfusionists. I don't know how, but that's fine. 9% said these procedures will have limited application and not affect pump surgery volume. I tend to be in that category. Let's bring Nate back in now. Nate, what do you think of those? Do you have any ideas?
Where we work, we're kind of more community centers. We don't do TAVRs at this point that I'm aware of. So for us, it doesn't affect us. I think in future it will. I've heard many times that these type of devices will eliminate pump surgery for valves in the future. But I think that's a fallacy, because what happens when they poke a hole in the ventricle? What happens when the valve pops off the stem? And
what are you going to do? What are you going to do?
We're going to go on pump. We're going to fix that.
How are you going to fix that? How are you going to go fish it out? Where are you going to find it?
I don't know, but they're going to have to do it. And I think it's going to require perfusion support to do so.
Yeah, I don't know, man. I don't know. I would think if something like that happened, it would be, especially on a patient, unless this is going to move into the very low risk. Look, I'm just going to ask you a point blank question, and I'll ask myself the same question. I'll even ask myself first.
Okay.
Would you have, so I'll answer just like I was asking myself. Would you have open AVR if you had just isolated, idiopathic calcific aortic stenosis? Would you have AVR or would you have a TAVR? For me, I would have an open AVR. I would have them do like a the parasternotomy, the minimally invasive technique, and just open it up and use that like that Percival valve, or the one that Edwards has one similar, where it's the sutureless valve. They put it into 3. We've seen Matoyer do those. They put in the stitches, 3 stitches, put it down, inflate it, tie those 3 stitches down, and they're out.
Yeah,
and it's a very short pump run, very short clamp time, and it seems to, they don't have to do as much debridement, and they seem to have really good outcomes with it. So for me, I'm a relatively low surgical risk. I'd rather have that done than have a TAVR. What say you?
I feel the same way at this point in time. If in the situation we're discussing, then yes, that's exactly how I would do it. Now, having said that, just say I had a cab tomorrow, and then 10 years from now or 5 years from now, I needed a valve. And the surgeon, it's the same surgeon, but he's been doing TAVRs now, and he comes to me and says, hey, this is safer because of your previous history. I'd probably consider a TAVR at that point. But just for an isolated, if I need a valve tomorrow, yep, I'm calling Bedair, Vanny, Duvall, one of those guys, saying, hey, when can you fit me in? I want you to do it on pump, open.
Well, if it's Patrick, I'm not calling one of those guys. I know who I'm calling, and it's not, you know who it is too, but I can't say it. Okay, so I'm curious, of course, again, if our audience has an opinion about that, I'd love to hear about it. We can even open the phone lines here anytime. So if you want to do that, and let's switch back to my slides again. Let me go through the rest of these. And then what are your responsibilities for TAVR or TAVI standby coverage? This was very good too. So just standing by for pump was 100%, but 43% did intra-aortic balloon pump monitoring, 26% did setup monitoring, which I don't know what that is, and 22% did TAVR procedure checklist, and 0% prepared the valve, thankfully, because I don't think that's really within our scope or in our purview. But nevertheless, they asked the question. Maybe that's where the new opportunities for perfusionists come in. We can be preparing the valve. Oh, here. I forgot to change the slide. Okay, there's the slide. Stand by for, I keep changing it into, I forget to change it in the second place. Stand by for pump, there you can see it right there. Setup monitoring, intra-aortic balloon pump, TAVR procedure checklist, and then preparing the valve. So going to the next slide here. Okay, now, take a look at that. Everybody, I want everybody who's watching to take a real good look at that. See that great big mass going back and forth from the right atrium to the right ventricle? Okay, so bring Nate back in. And can you have both Nate and I and the slides?
You can minimize me, it's okay.
No, we'll keep you on there. This is Nate's case. No, can't do it? Okay, so just go ahead and take Nate away for a second. So let me tell y'all, just for a second, Nate, you'll come back.
Yes.
So this is what they saw on the echo. Now what happened was that thing that you see there disappeared. It just disappeared. You see it, and then it was gone.
Of course.
Miss, are you telling us absolutely everything?
Not exactly. We're also out of coffee.
Don't panic. Don't panic.
Listen to me. Your crew is in complete control of the
Yep,
situation.
it only takes 5 minutes to set the pump up or less.
Absolutely nothing to worry about.
No concern at all. We're here. So really, you can bring Nate back and you can take my slides away. So Nate,
Yes, sir.
it isn't just TAVRs. I thought those slides on TAVR were important to show, but really we do standby for so many different things.
Yes, sir.
And that thing that you saw in the atrium there didn't originate back in the atrium going back and forth before it disappeared. It originated all the way down in the kidney. That was a renal cell carcinoma, right?
Right.
And we were kind of there on pump standby, but we didn't have the pump primed.
We didn't have a pump in the room because we didn't know what we were dealing with, unfortunately.
Mm-hmm. So what was it like?
We were told cell saver standby. He told me The surgeon informed me that he would like us there in case it was a bad bleed situation.
Okay.
Cell saver was what we were expecting. That was in the room. We weren't in the main heart room, which in the future with these type of cases, we will be, or I will pitch a fit. I think we will be with this particular surgeon. I don't think that'll happen again. It wasn't primed. There was no heater cooler. There were no cannulas. There was nothing, Joe. And yes, that's on me to some extent, but I honestly had no knowledge of the extent of the issue we were dealing with. After speaking to you, which you probably have a slide on this.
No, I don't. That was my last slide.
Okay, well, after
that was my last slide.
Cases, renal cell carcinoma tend to go bad and go bad quickly. And there will be a pump standby if I'm there in the future. It will be primed and ready to go. And if I can talk the surgeon into it, I'll have the lines on the tape.
So just so I'm clear, they actually didn't even want pump standby. They just wanted cell saver standby in case they started bleeding.
That's exactly what that's what I understood.
And then all hell broke loose.
Yes. Of course, we found out later, seeing the TE, that a chunk of the tumor broke off, shot up down the into the right atrium, into the ventricle, and then the vena cava just fell apart on us. And
but that big chunk ended up in the PA, right?
Yes, sir. My warning was, we might have to go on pump. We're going on pump, and it was quite literally that quick.
And
when he said we might have to go on pump, I started moving to the door because we have a core that we walk through to get to our main heart room. And I heard him say, we're going to have to go on pump before the door shut behind me. So it was less than 10 seconds between the words, we might have to go on pump, and we're going on pump. And we were probably on pump in under 5 minutes.
That's pretty good.
But my heart rate was elevated. I was sweaty. We were all sweaty. I was yelling at nurses, not in a mean way, but get this, get that. It's just it was a bad situation. It should have been, we should have had the pump primed and in the room at minimum.
Yeah.
Because and I don't know, what's the rough cost of a pump circuit versus a patient passing?
It's minuscule. It's nominal. It's insignificant when you look at the overall thing. But this is where you start getting into these other issues. Is you set the pump up, you prime it, you're ready for the standby, you don't use it 90+% of the time. Do you throw it away and set another one up for the next patient, or do you leave it and reuse it?
I think in most of our practice, we tend to reuse it. Of course, we're not passing lines off. For op-cabs and things like that. And even then, now, most of our surgeons, if they're doing an op-cab, they don't want us priming. One surgeon in particular will have your hide if he catches you priming. So the key there is to prime beforehand and don't say anything. But so we tend to set it up, leave it for a week. We have discussed it with the manager, Stephanie, and her plan in general is you send her a note and it's tore down within 5 to 7 days if it's not used.
So that's our policy on that.
That's our particular policy.
Okay. So now, of course, I take this a step further. You're doing do you set a pump up for a convergent procedure?
Such as?
The convergent procedure, where they do that atrial fib, where they go up to the cath lab and they snake a cath. It's some kind of burning unit. No, the Watchman is the left atrial appendage ablation.
I've never had them call me for a setup for that. I've never even had them tell me we were standing by for that. I have for atrial leads, but in general, we didn't set it up for atrial lead removals either. We just, we were just in the house. The idea is most of the time those aren't where I work before we were doing standbys. Those weren't done in the cath lab, not in a room. So the reasoning was, and it's poor reasoning, but this is their thought. If something bad happens, the perfusionist has time to prime, and get ready to get on pump before the patient's even in the room. But like I said, that's poor. In my opinion, that's poor reasoning. If we're doing this and we have hybrid rooms, and you're already charging for a standby for perfusion, what's the what's the additional cost of a pump circuit relative to the charge for pump standby?
It's minimal. And frankly, I think that if you're doing an op cab, the way I feel about it is I think the lines, because, when is something going to go wrong? Something's always going to go wrong when you absolutely have to have something. So we don't drop the lines on the table off the table very often. We don't drop the lines on the floor and contaminate them very often. But
Right.
if it's going to happen, it's going to happen during an emergency.
Yes.
So I am wondering whether or not we should not prime the pump and have the lines on the field on any of these procedures and have them there and ready so that we don't have to, in a hurry, prime it, get the lines up, everybody's frantic. The chances of something happening at that moment, now you have to make a choice. Do I use the contaminated circuit or do I wait and continue to do whatever it is that I'm doing, which is suboptimal anyway? It's rescue therapy. It's certainly, resuscitation is effective, but if you have to set something back up again, that's going to take quite a bit of time. If you just have to cut a line and add a piece to it, now you're running the risk of air. Anything can happen, and it's always a crisis. And I don't understand if it wouldn't make more sense to just have everything up on the line. And again, I'm curious what other people may think. If somebody wants to call in and give their opinion, it'd be great. Make a YouTube chat, be great. But I really am curious what other people do as far as standbys are concerned. I think if we're pump standby and you're in an operating room and there's a pump in the room, I think at the very least, it should be fully primed. I think if it's fully primed, I think the line should be at the table. You take it away, you tear it down, that patient bought it, whatever. CMS is paying for that patient at part of the DRG, whatever it is. It's just that's where it got used. You set another one up for the next patient. That's what I think.
Some surgeons, I don't think we would have any issue at all with some of our surgeons getting them to agree to that. But one in particular, who's the most prolific off pump surgeon we work with, I don't know if you want me to say names or not. So
No.
I'm trying to he doesn't even want us to prime the pump.
Mm-hmm.
He has yelled at one of our perfusionists before, who laughs about it. He was not offended, but the perfusionist laughs about it and says, "Yeah, but it's my license on the line. It's I'm the one. If I'm not ready, it's my fault."
Right.
So I agree with you to a good extent, but it's convincing the surgeons, and even then, if we start doing it, it's also convincing administration in the facilities when they come to us and say, "Hey, why are the costs going up? Why are we ordering more? Why are we ordering more pump packs? What's going on here?"
Mm-hmm.
Then we have to go and convince them this is a safety issue. This is a patient care issue. And I don't know. I think we need a broader response. A study might not be what we need, but we might need something that severe to say this is a standard of care, or maybe we should go. Organizations should be pushing that as a standard of care.
Yeah, maybe STS should.
Yeah.
What's STS say? They say something about everything else. Why don't they say something about this too? What is the appropriate way to do a pump standby? Maybe if that was a question, I don't know. I mean, I know it's rare, and I know it seems wasteful, and I do understand. I'm not insensitive to the economy of what it is we do, and we certainly do waste a lot of money. But if you're in an operating room and your chest is open and they're doing something to you and you have to be there, the cost of us being there versus the cost of the pump versus the cost of all the other stuff that's in there, it's such a small slice that to me, it just doesn't make sense. And I think, again, at the very least, prime the pump. If it's me, if my family's having surgery, if it's me having surgery, I'd rather you handle. That's just me personally. That's how I feel for the ultimate in safety. Maybe that doesn't make sense in most circumstances because it doesn't happen that often. But man, every time there's been a problem, it's always chaotic. It's always a scramble. It's always a rush. Everybody's, you've got the scrub nurse who has to take the lines from us. You have a major bleed that's taking place. You have the surgeon screaming for the lines. The nurse, what's happening? You got what's
Child.
child? Oh, that's good. Bring him in your lap. Or is you bringing you drink?
Say hi. Emily, come say hi.
Give him some give her some alcohol. That's
Say
always
hi.
good.
Say hi.
Hey, you're on the air.
Tell them what you want to do for a living when you grow up.
I'm gonna be a mom, and I'm
Wow.
gonna be a mom.
A mom, okay. You don't want to be a perfusionist. At least you're smart enough to know better than to do that. Okay.
A doctor too.
Good
Perfect.
for you. There you go. A doctor. Very good. Very good. So,
Sorry, guy.
yeah, so it's always going to be chaotic. So they're bleeding. They need suture. They need clamps. They need this. And we have to get our lines up. So we're
Right.
standing there with the lines exposed, wanting them to take the lines, but the surgeon needs a clamp, needs laps, needs something, and you're trying to do all these things at one time. It's always a chaotic circumstance. And to me, it just makes more sense to just have it there and ready. It's right there already. You don't need
Right.
it, fine, throw it out. The cost as far as like I said, the cost compared to the cost of everything else combined is nominal. It's an insignificant amount.
Right.
And we're there anyway. They're paying for us, and we're a lot more expensive than the thing. So get rid of us too. Doesn't make sense.
Don't say that too loud, because if he's watching, the surgeon we were talking about, he would probably do that.
Go ahead. Go ahead. Don't call me when you need me. Okay? I'll be busy.